So we'll go ahead and get started on chapter 20. This is over gastrointestinal and urologic emergencies. This will be a really long and actually a pretty difficult chapter because there's a lot of stuff in our stomach and everything, or in our abdomen and in our GI system and urologic system. And so that means there's a lot of things that can go wrong. In fact, obviously each organ has multiple pathologies, and we got to talk about what those are and how we treat them and all that. So the idea of these videos are to not read the slides to you or read the book to you, but to try to explain to you the pathology um, in concepts, right? To where if you can conceptualize where the appendix is and if it's inflamed, the types of signs and symptoms the patient would present with, I think that's a lot better than just saying appendicitis equals right lower quadrant pain. But that's not enough to get questions right on exams, right? So that's kind of the idea of these videos, is to share concepts and to explain these pathologies. And in fact, when I was preparing for this lecture, I'm always a little bit surprised with how much they want EMT students to know. But it reminds us that emergency medicine is really broad. And so, we're a mile wide and an inch deep in a lot of different specialties and topics. And that's why this becomes challenging, is because of how wide emergency medicine goes. There's virtually no boundaries. So we'll go ahead and get started. But, abdominal pain, it's a very common complaint. And, we see this a lot. A lot of people will call 911 for abdominal pain. And it's actually difficult to identify, like, what is the cause of the pain. Some pathologies, which we'll talk about, are slam dunks and they're easy to find, but a lot of them aren't. And so, physical exam and history taking, I would say, physicians would agree with this. I've talked about this in previous videos, are probably 70 to 80% of your diagnosis. It's just a good old physical exam and history. And you can usually get to a narrow window of what the actual diagnosis is going to be. Imaging and lab tests, which we don't have in the pre-hospital environment, but even with those, they're not always very helpful in in abdominal pain complaints. Okay, so the good thing is, in as an EMT or even as a paramedic, we don't have to figure out the exact cause always, right? Your diagnosis may just be abdominal pain. But it's helpful if we know, oh, this is abdominal pain from appendicitis, or if this is abdominal pain from a lacerated spleen, or whatever the pathology is, because sometimes that does make a difference in our care. And that's part of being a clinician and not a technician. So the big take home from this, which we're going to get into some details and some things that you may think are not important, but the big takeaway on this is we have to be able to recognize life threats, right? And fix those and react swiftly, right? And so that's kind of the idea of abdominal pain complaints is, okay, they're having abdominal pain. It could likely be this list of things in order of seriousness to least seriousness. And we're going to, stabilize and transport. And as an EMT, you're fairly limited with what you can do. But at a minimum, we can provide comfort and transport these patients. And so we'll talk about that. Again, I'm going to show you some things on here, but if I'm telling you it, I think it's pretty high yield, and we probably need to know it. So I'm not here to beat you up with low yield garbage, okay? So you should know that the abdominal cavity, right, has hollow organs and solid organs. I've seen on exams where they'll test your anatomy knowledge and they'll just straight up say, is a spleen a hollow organ or a solid organ, right? And so you should know, obviously, the spleen, which is here, is a solid organ. And that's how I've seen them try to test this before. But they'll do one that's more complicated, like the gallbladder, right? The gallbladder is a hollow organ, the large intestine, small intestine, stomach. So that's kind of how they'll occasionally test, your understanding of anatomy and physiology, is to know if it's a solid organ or a hollow organ, excuse me. So this is out of y'all's book. Remember, we divide the abdomen typically into 4 quadrants, okay? And so right here is what they call the coastal arch. It's kind of like the arch of your rib cage. And so what you assume is that there's abdominal contents up underneath the rib cage already, right? So, like, we'll just draw something real quick. Let's say the rib cage ends there. Your liver, right, is still sitting up here underneath up underneath the rib cage. Same thing with the spleen. The spleen's sitting way up here up underneath the rib cage. So just be aware that the ribs do cover some of your abdominal contents, namely the kidneys, mostly, the spleen entirely on a normal day, and the liver, a good chunk of it. is covered by the rib cage. So I'll say that again because that's important to know. The ribs, the lower segments of the ribs do cover some of your abdominal contents. They don't just stop at the lungs, okay? So, yeah, I won't get off topic. But anyways, we should know that these are divided into quadrants. And the reason that this becomes important is because we like to know what's in each of these quadrants, right? So, for example, if, 17-year-old males complaining of left lower quadrant pain, it's almost always what we call FOS, full of shit, right? They're constipated, typically, would be a very high up diagnosis on your list that you would think, oh, they're constipated. As opposed to a 17-year-old female that has left lower quadrant pain, you would think, oh, they're FOS, right? They're constipated, or it's an ectopic pregnancy, or it's an ovarian torsion, or it's an ovarian cyst, right? Or it's not endometriosis, but it could be all these different lady part pathologies. So that's important to think about, and that's why we use this quadrant system, because we know that what's underneath the quadrant narrows down what we should be thinking our diagnosis is going to be. So there is the 9-quadrant system. This is used occasionally. And so it's just worth knowing. It just divides it a little bit further. What happens is the boundaries become the clavicles. So remember the clavicle is these bones right here, right? You can feel them on yourself. So you take midclavicular, right? And that divides them into that section. So it divides into 9. You don't see this very often. Where you do see this seen a lot actually is the epigastric region. So you'll hear someone say they have epigastric pain. They're talking about right about where the stomach sits, okay? The majority of the stomach, and especially where you'll feel stomach pain. So that's this area right here. So epigastric pain, very common complaint, and you'll hear that thrown around a lot. So that's probably the one that I would know the most on there, okay? So the entire digestive process should take 8 to 72 hours, right? If you've ever eaten some corn, you can track this in yourself, right? Like whole kernel corn. All right, just ruined my joke. But anyways, you probably know what this runs about in yourself. So we should be able to trace a drop of food from the mouth to the anus, right? So the salivary glands actually, they're not just there to like moisten your food, but they actually start chemically digesting carbohydrates in your mouth, right? And they also lubricate food. So there's a chemical reaction and there's a physical mechanism to this, right? Once it's swallowed, right, it goes back through the food tube behind the trachea. It's called the esophagus, right? And so once it goes from the esophagus, it'll go down to the stomach. Okay, let's just draw this out here, right? Now we're into the stomach right here, right? From the stomach, it'll go into the duodenum, through the jejunum to the ileum, right? So how I remember that is DJI, duodenum, jejunum, ileum, okay? I didn't name them, so don't take it up with me. And then so from the ileum, it dumps over here into this thing called the cecum, right? And that's spelled, we'll talk about a pathology here called appendicitis, the cecum, right? And from there, this is the ascending colon, transverse colon, descending colon, sigmoid colon, because it's shaped like an S, rectum, anus, right? So you should know that pathway. Honestly, I think you should know that as just a human being. But anyways, you should be able to explain that pathway to me in class. So realize there's which we're going to talk about esophageal varices, but this becomes important from pharmacology stance too. When we eat something, right, whether it's a pill ingest, right, when we eat a pill or we eat, right, Taco Bell or whatever, this whole system that we eat upon goes to the same venous system, and that venous system is called the portal system, right? Like portal vein, right? And so it goes through this thing called the portal vein. So what does that mean? That means that your small intestine, your stomach, your large intestine, almost all of your large intestine, well, all while it's digesting food and absorbing nutrients or breaking down substances of that pill or whatever, it's all going back through to this one really, really big vein. And this really, really big vein that all the digestion will go back to the liver is called the portal vein. And they're showing you that, and cool, right here. This big one right here. It's really big. And so basically all these tributaries and rivers go into this really big vein. And it's called the portal vein. And the portal vein dumps all the nutrients that we just ate or all the substance of the pills the patient just took into the liver for processing. So in the liver, as it's processed, it's shot out through this thing called the hepatic vein into the inferior vena cava. Okay. So test question: where does and they're not going to get you on a really tricky one, but it's just what you need to know. I'll say this in one sentence, right? All the digestion blood will go back to the liver through the portal vein, all of it. Okay. And that's very, very important to know because this is why when we ingest a pill, it's sent to the liver. And so it goes through metabolism in the liver. And so this is an important process to know that all venous blood goes through that we eat from ingestion, from eating basically, will go back up through the portal vein. And there's pathology with this. We'll talk about it. It's just you get problems with this in cirrhotic liver disease like hepatitis or alcoholic liver disease or fatty liver disease, stuff like that. So we'll talk about that some more. So we should know where the stomach is, right? It sits really kind of in the middle. It juts off a little bit to the left, but here's a little schematic for you, okay? Um, and so it secretes this very acidic product, hydrochloric acid, that breaks down food. There's also stuff in there we won't get into that. But let's just say it's acid, okay? There's a few other chemicals that kind of join up in there that help with digestion, but we'll talk about that later. But acid's the main one, okay? But you should know that stomach does absorb water, alcohol, and caffeine, okay? So if you've ever, I'm trying to restrain myself because I don't want to confuse you, so I apologize. So it does absorb water, alcohol, and caffeine. It also absorbs aspirin as well, which is kind of random, but it does. Okay. Um, so the liver it is very large. It is a solid organ. However, it has a hollow organ within it called the gallbladder, but it's a solid organ. Again, it filters toxic substances in the body, especially things that we eat. Everything that we eat has to go, like all the nutrients of that's absorbed through the blood will go up to the liver for processing. Okay. So it also stores glucose and glycogen, right? Remember, glycogen is just glucose on a chain to where when your body gets hungry, it can just start popping them off that chain for energy. Okay. And so the liver also plays a really big role in clotting factors. So when people have liver disease, they tend to have bleeding diseases because their clotting factors aren't working well. The liver has a big role to do in cholesterol maintenance, right? It also plays a big role in immune function. So the liver is very, very important. But the big thing when you hear liver, I want you to think digestion. It helps with filtering toxins and removing toxins, metabolism, glucose. Pretty much everything on here is fair game in the high yield overarching section of the liver. Okay. Now this remember it goes in this order, and I think there's a drone called like a DJI drone. Maybe I'm making that up, but it goes duodenum, jejunum, ileum. And so basically, right after the stomach, right here, there's a little sphincter. You're already in the duodenum, okay? And so it goes duodenum, jejunum, ileum. And each section of this small intestine, they have different properties that help with absorption of, per se, iron versus bile acids versus protein or whatever. They have different roles. So while it is just the same cylindrical small tube, the small intestine, the reason it's divided like this is because they have different, like if you were to look underneath a microscope, they all look different. And so they have different jobs. And so that's why it becomes important. Okay. Now, these enzymes, jumping back, will turn the food that we've just ingested into something called chyme, right? CHYME. And so that is sent through the small intestine to hopefully be absorbed, what we can absorb, and you'll poop out what you don't need, hopefully. So the large intestine, remember, the ileum ends right here. Duodenum, jejunum, ileum, DJI, right? But the ileum ends right here and it dumps into this thing called the cecum, right? And this is on the patient's, I'll draw this for you. This is on the patient's right, this is on the patient's left, okay? So on your right side is where your small intestine, right lower quadrant, dumps it all that chyme into the large intestine over here at the cecum. It goes through the ascending colon, transverse colon, descending colon, the sigmoid colon makes an S, into the rectum and expelled through the anus, right? And so you do need to know that order, okay? Now, the primary role of the colon is to reabsorb water. So that is a really big function of the colon. And the other part is this is where the bacteria will live that aid in digestion and maintaining like the gut biome, right? The bacterial balance of bacteria. in your intestine. That tends to be more so in the large intestine. Okay, so just be aware that it goes ascending on starting from your right. So guys, on the exam where right now when I'm talking to you, you could draw this on yourself, right? So I go ascending, transverse, descending, sigmoid makes an S, rectum, anus. Okay, you don't have to draw it that low. Just kidding. All right, so the spleen is a part of the abdominal cavity, but what's really weird, and what's really weird is it doesn't have any digestive properties. It doesn't help with digestion. Okay, so the spleen is part of the lymphatic system, right? Remember, the lymphatic system is kind of like the body's trash can, lymph nodes, right? To where it just kind of picks up little bacteria and it stores white blood cells and it picks up this watery fluid stuff called lymph, and so it does a lot of things. And I don't think that as paramedics or even as humans we appreciate the lymph system enough, but it does a lot of things. So the spleen again. So test question, right? Which one of these organs is not involved in digestion? Esophagus, stomach, large intestine, duodenum, uh, you know, descending colon, or spleen? The answer is spleen. The spleen does not participate in digestion at all. Okay, where is the spleen located? Okay, the spleen is located in the left upper quadrant and it should be covered by your rib cage. Okay, so for example, you can see this in this guy, right? The rib cage would be drawn like this, and so the spleen is up here and it should be covered by the rib cage normally. And so the reason this becomes important is if someone takes a baseball bat to the left side of the rib cage, right? And they tell you that in a test question, you need to be thinking, oh, the spleen's there. That's the spleen. The spleen can bleed. So the spleen, its main role, one of its biggest things that it does is it filters the blood. And what it really does is it filters the red blood cells. And so red blood cells live about 4 months. That's not important, but they live about 4 months. And so at the end of their 4 month life cycle, the spleen will be like, you're mine, buddy. And it just grabs them out of the circulation and destroys them. And it recycles its products. And so, what are its products, right? Heme, which will turn into bilirubin, right? We piss that out, and that's why your urine is yellow. And then also globin, which is a protein, it ends up being reused. So, just be aware the spleen is the one that will filter out the blood and decide which blood cells are good to keep circulating and which ones need to be destroyed and recycled. Okay. So it aids in the development of red blood cells and it serves as a blood reservoir. So you should know that the majority of macrophages, right? Those are these very big Pac-Man guys that go and chew up bacteria. What they're stored in the spleen. Okay, so a lot of white blood cell products are stored in the spleen. That's also where white blood cells tend to go to mature, right? So they'll go to the spleen to learn to go to college and learn how to go fight infection. Okay, so because of this, since they went to college, right, in the spleen, these white blood cells, they produce antibodies to help fight off disease and infection. So the spleen, let's recapitulate this, right? It sits in the left upper quadrant. It's mostly covered by the ribs, okay? It has a very rich blood supply because its main job is to take care of the blood with recycling red blood cells and destroying them. It also matures and white blood cells and sends them to college to produce antibodies. It also stores the majority of the body's macrophages. So with all that to be said, that is the spleen. Now, the spleen can be surgically removed for a number of reasons, especially if it's injured. And so you can live without a spleen. You're just at a much higher risk of infection. And so that's kind of worth knowing. There's a couple pathologies where we decide to remove the spleen, or it can even remove itself in like sickle cell disease. So just be aware, spleen sits in the left upper quadrant. You need to know that because what's going to happen when we're not trauma yet, but when we get to trauma, they're going to say patient has a flail segment to the left lower rib cage, right, which would be here, the left lower rib cage, and you're going to have to be like, oh wow, the spleen sits there. The spleen's probably injured. So the spleen's like hamburger meat, right? And so if a rib punctures the spleen, it will bleed and bleed and bleed and bleed. And so then you end up with bleeding into the abdomen and the patient loses too much blood, hypovolemic shock, peritonitis, all these issues, right? So that's worth knowing. Now, one thing I will say, when the spleen gets irritated, patients can fill this up into their left shoulder. That's called Kerr's sign. Kerr's sign, right? So just be aware of that. The reason is the diaphragm sits right here. The spleen sits right up underneath the diaphragm. And so what happens is there's a nerve that runs up, the phrenic nerve, that runs up through the shoulder into the neck. And so what happens is they'll end up feeling pain up in the shoulder and the neck on the left side. Worth knowing. Now, this slide is very complicated, but we're just going to run through some general anatomy because there's an entire chapter on this. But they did want to start talking about the male genital system. So for now, excuse me, I'm just going to point out what's on the slides. When we get to the other chapters, I'll point out a lot more that you're going to need to know. Okay, so we'll just take our attention over here to the female side. Okay, so the female side, um, there's the okay. Let me say this. Well, I won't get into that. Let's just start with this. Here's the ovaries, right? So men, right, that are watching this video, you need to know that the uterus and really the ovaries kind of sit where our bladder sits, right? Women will know this, right? But the uterus and bladder sit really close to each other, okay, almost on top of each other. So if you've ever had to like pee really bad and you feel like that pressure really low down on your abdomen, right? That would be the equivalent of where the uterus would be, okay? So that can give you a reference, because you cannot relate to having ovaries or a uterus, of where that pain would be, okay? I think it's important for me to point that out. Where is this? Because I think sometimes men may think the uterus is like way up here. It's not. It's really low. It's down there by the bladder, okay? Now, in women, the primary gonad of a woman, or the only gonad, right, is an ovary, okay? And so this is the equivalent of a male's testicle, right? But in this case, it's producing an egg, right? And so what happens is this ovary, once a month, every 28 days, should release an egg, and it's picked up into this thing called the fallopian tube. And so the fallopian tube will pick up this egg, and it'll travel through this tube and maybe become fertilized or not, doesn't matter. And if it doesn't become fertilized, it comes over here to the uterus. The uterus is right here. It's this thick, smooth muscle that's normally about the size of a pear or a fist when it's normally, not when it's not pregnant, right? And so what happens is this egg will travel down, and if it's not fertilized, right, it'll be the lining of the uterus and the egg itself will be shed out through menstruation. So the woman will have their period, she will bleed, and so right here is this thing called the cervix. The cervix, like a cervical collar, right? It means neck. So it's kind of the neck of the uterus, and so this is the cervix, and there's an opening right here called the cervical os, right? And so this is where the products would go, and then it'd be expelled through the vagina, and then out of the body. So that's a very rudimentary, elementary level understanding of female reproductive anatomy. But you should be able to, if there was no picture or like no words here, you should say, "Oh, that's the ovary. This is the fallopian tube. This big thing is the uterus. This area that looks like a neck is called the cervix, and here's the vagina." Right? So you should be able to know that and be able to spit that out. Okay. Now, in males, it's obviously a little different. So in males, the primary gonad is the testicle. Obviously, these sit within the scrotum. The scrotum is the skin and the connective tissue around the testes. Okay. And one thing to point out is that I think that sometimes we may erroneously think that the testicle is just one solid, like round mass, right? It's not. This is the actual testicle, and we have this thing called the epididymis that sits on top of it. So it's like if this is the testicle, there's something that sits on it. This little something that sits on it is called the epididymis. Okay, and so then we show that to you here, right? So like here's the testy, and then there's the epididymis, and then it travels. So we're just talking about sperm, right? We'll just talk about ejaculation, right? So sperm is created inside the testes, right? And then it travels through the epididymis, through the vas deferens. If you've ever heard of a vasectomy, right? It's where they cut this right here. But we'll keep going. So the vas deferens, and it'll travel around into the prostate where it'll mix with some fluid. This is where, again, we're talking about ejaculation. And then it'll travel out through the urethra, and it'll be expelled. Okay. So we just talked about all of these structures just by explaining how the how ejaculation takes place. Okay. Now the urinary system, it's a little different, right? That we were talking about just strictly about reproductive earlier, right? But of course, there's overlap between the two, like the urethra and stuff like that, the penis. But the urinary system, we should start with the kidneys, and this is the patient's right. How do I know this is the patient's right? Because the right kidney sits a little bit lower, and so we should know that there's a tremendous amount of blood coming into the kidneys, okay, and it's filtering our blood all day until we die. And so it's what it's doing is it's pulling out toxins and some water from your blood with those toxins and electrolytes and stuff like that out of the blood, and it's sending it through a very complex system down through the ureter into the bladder, and then from the bladder it'll be expelled through the urethral opening, right? It goes through the urethra. Now, why am I so persistent on the word ureter versus urethra? It's because students confuse this. So ureter sits in the back, right? Right here in the flank. You can't feel them, but you can imagine where that would be. So it's in the patient's back. Why does this become important? Because kidney stones can get lodged up in these, and it's extremely painful. So the patient will complain of flank pain. And so they'll describe a patient who has kidney stones, and the student will be like, "Oh, there's an obstruction of the urethra," and that's wrong. It's an obstruction of the ureter where they're having the flank pain. So just be aware of that. That the ureter sits in the back in a male and a female, and the urethra is the opening to the world, right? So that's from the bladder to the end of the penis, right? So that is the urethra. So ureter is first, then urethra. Okay. Now the bladder is a smooth muscle. Um, and so I don't have a lot to add on that. It can expand quite a bit in size. It's pretty impressive with how small it can get to compare to how large it can get if it gets very full. So I guess it's kind of worth knowing. Okay. Now I'll move over here. The the two main functions of the kidney is again to regulate electrolytes, water content and acids of the blood. And because of what it does, it consequently, well, really by design, it regulates blood pressure too. So kidneys equals blood pressure, kidneys equals blood pressure, kidneys equals blood pressure. And a lot of the pharmacology treatments we use to manage blood pressure, we target stuff within the kidneys, okay? So the kidneys obviously control your water content, they regulate electrolytes and acids. Remember, if someone becomes acidotic, what's the first thing to respond? It's our respiratory system. It responds in seconds. What responds 12 to 24 hours later? The kidneys. Okay, the kidneys are slow to respond to acid issues, but they do play a very vital role. Okay, so they remove the metabolic waste, drug metabolites. The majority of drugs that we ingest are removed through the kidneys, right? And excess fluid from the blood. So they filter about 200 liters of blood a day. So how much is a liter? This is a liter water bottle, right? So I mean, think about the volume of that. Tremendous amount of volume is going through the kidneys every day. Excuse me. And so that's worth knowing. What I'm trying to show you here is, again, this is the patient's right. The right kidney sits a little lower. Is there's a lot of blood that goes through here, and it goes through the functional unit of the kidney called the nephron. And I'm not going to explain this very hard, but basically there's a lot of blood circling in this like little circular like pattern, and some of it gets filtered out, right? It gets squeezed out due to pressure, and so that's where you end up with this hyperfiltrate, and then through this whole system, stuff's getting reabsorbed. Okay, so a lot of it goes out, and a lot of it gets reabsorbed. But what doesn't get reabsorbed comes out through the kidney pelvis, which is this thing, down through the ureter into the bladder, and it's expelled through the urethra to the opening, right, into the toilet. So that's the normal location of this. Now, I won't, you can actually feel a little bit of the right kidney if you push really hard on the front side, but you probably don't even know how to do that, but you can feel a little bit of it, okay? Now, the kidneys do produce this stuff called erythropoietin. You don't need to know the name, but they do tell the body, create more red blood cells, okay? So that's worth knowing. And they play a major role in maintaining homeostasis. Remember, homeostasis is just the balance of life. And I just told you this, but the nephron is the functional unit of the kidney, okay? So just like the neuron is the functional unit of the brain, right? But the nephron is the functional unit of the kidney. Whoops, let me fix that. All right, there we go. All right, so let's just start talking about pathophysiology. We have this thing in EMS called the acute abdomen, right? And so this is the sudden onset of abdominal pain. And where we see this a lot is in trauma. We see this a lot in trauma, right? And so basically it can and usually will indicate something called peritonitis. And we know that we have this lining that goes around our guts, right? Especially like the ones in the front side, like your intestines, okay? Your stomach, stuff like that. And so that's called the peritoneum. And what happens is the peritoneum, it's almost like saran wrap, right? Like I could describe it as like almost like saran wrap, like the stuff you would put over leftovers. And What happens is it does not like it when blood, like straight up crude blood, sits on top of it because it's very blood itself is by design is very irritating to the peritoneum. And so when blood sits on the peritoneum, it gets inflamed very quickly, and it's called peritonitis. Remember, itis just means inflammation. So the word peritonitis means inflammation of the peritoneum, right? And that's the saran wrap stuff that sits around our guts. And so we can get a condition called peritonitis in something called like with infection, right? So if you end up leaking poopy products into your abdomen, right, that's going to give you infection, peritonitis, right? The other way this can happen is through trauma. So if you take a baseball bat, right, or a gunshot wound to the abdomen, you're going to get blood that's leaking into the peritoneum, peritonitis. You can also get this through several diseases, right? Like pancreatitis or through, I mean, the possibilities are endless, but you can get this a lot of different ways. But when you hear peritonitis, there's a hallmark, there's a few things that make peritonitis stand out to us. The first one is you need to think, well, there's some type of irritating fluid in the abdomen, usually blood. And what's interesting about peritonitis is it's so irritating that bumps hurt. So the hallmark of peritonitis is these are the patients on the stretcher. You know, like on a stretcher, when you go over the thresholds of a door, it's like da-dunk, da-dunk, right? Or a speed bump in the ambulance, or you hit a pothole in the ambulance. Bumps hurt, right? So when they get jarred, it hurts. It like jars them, right? They're like, ah, like it hurts, or they'll groan or grimace when you hit the bumps to like going over the threshold of a door, or going downstairs, or hit a speed bump in the ambulance, or whatever, hit a curb. So the thing that you should watch for with peritonitis, these are the patients that when they get like bumped, it hurts. And we could see the same thing. We could induce those bumps, right? So if I were to take my hand and dig it into my abdomen, right, and let go, that bump is called, if the patient grimaces with that, that's called rebound tenderness. Okay. So what I could do is like appendicitis, for example, right? We'll have peritonitis because the appendix, we're going to talk about this, will sometimes leak some fluid into the abdomen and it'll piss off the peritoneum. And so what we can do is we can take our fingers and push into the patient's right lower quadrant and let go. So you push kind of firmly but steadily, and that'll be uncomfortable. But when you let go, they're gonna be oh, like they're gonna hurt. Okay, and so it's the let go, that rebound, called rebound tenderness. That's like that sounds like peritonitis. So that's why this is important to know. Okay, now they go a little further, and this is easy. This is easy stuff. But the parietal peritoneum, this lines the abdominal cavity. Okay, so this is like on your abs, right? On your abdomen, like the muscles, right? And so it can perceive sensations. Okay, so it's very particular. So if you have peritonitis, like in the right lower quadrant, and the patient will be like, no, it hurts right here, right? It's very distinct, as opposed to this stuff called visceral peritoneum, right? This stuff, it's not very innervated. It's very broad pain. So when I hear the word visceral, I don't know why, but I think of the word like vital, right? Like visceral, vital. And our organs in our abdomen, they're visceral, right? And they're very vital for us to live. So when you think visceral peritoneum, I want you to think these are the vital organs that keep us alive, and they're covered in peritoneum. So visceral peritoneum covers the vital organs. And so this covers the surface of the organs. And so basically, to recapitulate, you have visceral peritoneum covering your stomach, and you have parietal peritoneum covering the wall of your abdomen. And so what happens is that space between those is called the parietal space, right? The peritoneum. And so that's the distinction between the two. Now, again, with visceral pain, it's you'll see this like with stomach pain, for example, right? Like it's kind of broad pain, it's not very well defined. It's just it's you'll see this with like a bowel obstruction even, right? Or even diverticulitis, right? It's not very well. It's like the pain's right here, as opposed to parietal peritoneal pain, right? It's like no, it's right here. So the difference between the two is visceral pain is not well defined, and it's usually in hollow organs. Okay, and so what happens is you can end up with something called referred pain. And we've talked about this, right? And so, for example, remember me talking about the gallbladder on the left side? When they get pain here, they'll fill it up in their shoulder. The same thing will happen and the gallbladder. So the gallbladder, remember, it sits in the liver in the right upper quadrant, okay, mostly up underneath the rib cage, kind of. And so what happens when this thing gets all irritated? It will create pain up here into the patient's right shoulder, the patient's right, okay. And so that's a very distinct hallmark of gallbladder pain is they could have right shoulder pain. And it's really weird to the patient to be like, my shoulder's killing me and I have nausea and vomiting, right? And you're like, oh, okay, that's weird. Did you hurt it? Did you fall? Have you injured it? And they're like, no, 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 no. And then you just have to realize, oh, this is referred pain. This is referred pain. So referred pain is really tricky. But, again, the common shoulder ones that'll mimic it is pancreatitis or cholecystitis, which is a gallbladder issue up in the right shoulder, and then something with the spleen in the left shoulder. Okay. Now, peritonitis can also create something called ileus, and an ileus means lazy bowel, right? So this word ileus means lazy bowel. And so what happens is when the bowels get lazy, they don't move. And so an ileus means a bowel that has stopped moving or it's slowed its moving for whatever reason. So, for example, when someone has surgery, they have a degree of peritonitis. You just put blood in their abdominal cavity. So what happens? They end up with an ileus. So this is why surgeons get real worried about patients farting and eating and peeing and pooping after surgery, because you want to make sure that the bowel's going to work. Okay? And so an ileus means like a lazy bowel. And so with peritonitis, when the area over there gets inflamed, the bowel will kind of freak out and just throw its hands up in the air like a scared child and just be like, I'm not going to do anything. I'm just going to sit here. And so you end up with an ileus. And so that can create its own list of problems, right? But peritonitis is also associated with a loss of body fluids into the abdominal cavity. We've talked about why that is. Namely, blood is a really big issue when this happens, right? Fever may or may not be present, depends on how acute it is, right? And what the pathology is, right? Appendicitis can present with fever, diverticulitis, cholecystitis can all present with fever, but they don't necessarily have to, okay? So it may or may not be present. It really just depends on the timing and a few other circumstances. And then, uh, yeah, that's peritonitis. So we're going to talk about each of these, so I'm not going to read this to you. If you want to screenshot this, you can. But we're going to talk about this. So what I will point out about this slide is it's logical, right? If I tell you the appendix is in the right lower quadrant, guess what? They're going to have right lower quadrant pain, right? And so they have rebound tenderness because of peritonitis. So these are, same thing with cholecystitis. This is a infection of the gallbladder. And so they're going to have right upper quadrant pain and right shoulder pain. I just talked about why. But we're going to talk about why each one of these happen, okay? Now, any condition that allows foreign material into the abdominal cavity can result in peritonitis and acute abdomen. So if that would be food products or, fluid or blood or pus or bacteria or whatever, it can lead to peritonitis or the acute abdomen, okay? And so almost every kind of abdominal pain can cause acute abdomen. Yeah. So you can end up with this thing called, and this picture doesn't make sense. It makes more sense later, but called gastrointestinal hemorrhage, right? So you can bleed from your guts, okay? And so this can happen for a variety of reasons, right? But bleeding within the GI tract is a symptom of a disease. It's not the disease itself, right? And so that's like someone vomiting blood, right? That means, yeah, that's a problem. But why are they vomiting blood, right? Do they have a peptic ulcer? Do they have esophageal varices? Do they have a Boerhaven syndrome, right? Mallory-Weiss tear. We're going to talk about all these. So it's more so a sign and symptom to be vomiting blood or to be pooping blood, right? And so that's something to know. That's not the disease itself. Something's causing that. We need to figure out what's causing that. Okay. So this can be acute or chronic. A lot of times you'll find these are chronic, but sometimes we get called out when they're acute exacerbations. And this can happen in the lower or the upper GI tract. We're going to talk about what this looks like. So I'll tell you. If it's in the upper GI tract, it can look like just straight up frank, what they call frank blood. If someone's being frank with you, they're being very obvious. So it could look like frank blood, so obvious blood, or it could look like coffee grounds. Okay, so someone could vomit up what looks like we've all made coffee. Like when you finish making coffee and it's like that coffee grounds, right? It could look like that because when blood's partially digested in the stomach, it looks like coffee grounds. Okay. So it could look like that. And then if it's lower, it could look like tar, like tar we put on the roads, right? And that has a special word called melena. And it could also look like something called hematochezia, right? So this is blood with, or this is poop with streaks of blood mixed into it, or it could just be frank blood. They could just literally be pooping clots of blood or just straight up blood, right? So these are lower terms, okay? So, uh, what is it called when someone vomits blood, right? Hematoemesis. Remember that? So anyways, esophagitis, this is, I mean, yeah, this happens, but basically the esophagus is the food tube that lines, it's behind the trachea. If that gets inflamed or irritated or it's torn or whatever, but in this case, if it just gets inflamed, you could have a little blood from that. Okay. So you get this usually from irritation, this could happen from eating food that's too hot is a common complaint. Alcohol can cause this. Stomach acid can cause that. Okay, but really, let's talk about a more very, very common pathology. In fact, I'm sure someone in this class has this disorder, but this is called GERD, right? Or gastroesophageal reflux disease. Think about what that word is. So this is where the gastrointestinal system, right, meets the esophagus. So gastroesophageal. So that's this area right here, right? Reflux. So reflux is when something goes the wrong way, right? It's spit back up. Okay. And so basically normally we're supposed to have this sphincter that's between the esophagus and the stomach. And what happens is when we swallow, this sphincter should open up and then close back as soon as the food passes. Well, what happens is people, for a variety of reasons, eat too much, or there's another pathology we'll show you that cause this muscle to become incompetent, right? So it doesn't work very well. And so what happens is the stomach contents, namely acid, can be shot back up through this weak sphincter, this incompetent sphincter, into the esophagus. Well, the esophagus isn't really made for stomach acid, so when that happens, it burns. So this is heartburn, right? But this is like the more severe form of it that's chronic. GERD, right? Gastroesophageal reflux disease. And so what happens is over a period of time, you can get so much damage here. You can end up with cancer actually, but you can get bleeding. Okay, the patient can kind of spit up some blood or vomit blood occasionally, but this becomes a problem. And if someone's obese, a lot of times they'll present with something called a hiatal hernia, and this is where part of the stomach. So this is the diaphragm right here. Remember the muscle used for breathing? Well, the esophagus has to go through the diaphragm to get down into the abdominal cavity. And so what happens is the stomach can be shot up through the diaphragm a little bit, and it kind of stays up there. And so you end up with a hiatal hernia. And so the people that have hiatal hernias have really bad GERD. So this a lot of times you have to get the surgically fixed because it creates so many problems. And the risk of cancer is pretty high if you go a long period without fixing this. Okay, it's avoidable. You can just fix it. There's several surgeries you can do to fix this. There's medicines too that we give to fix this. Okay, now we know what an ulcer is, right? But we've seen ulcers on skin or whatever like that. But ulcers can happen in the stomach and in the bowels. And so we have this thing called peptic ulcer disease, where you'll end up with like an erosion of the mucosa, right, the inside of the stomach or the bowels or something like that. And so what happens is when that happens, it bleeds, right? So like you're kind of like scraping away the top layer of the bowel or the stomach, and so of course eventually, if I were to do that to your skin and just keep rubbing and rubbing and rubbing, it's going to bleed. And so, as you can imagine, as food and acid goes past this, it's painful, one. Two, it doesn't heal very well because it's constantly being irritated by acid and food. So can be very difficult to heal completely. So you end up with chronic disease with this. Now, the most common reason this happens is this pesky bacteria called H. pylori, Helicobacter pylori. And so this is pretty common in the United States. Even a lot of people have this bacteria, and it's very hard to treat. It takes a long time to treat because think about it. This bacteria can survive in your friggin' stomach, right, with a pH of 2 or 3, right? Very acidic environments, very harsh environments. So it's very, very difficult to kill this bacteria. It's possible we do it, but it's very difficult. Okay, so H. pylori, which this is a bacteria. Again, bacteria. Whoops, ripped my handwriting. And then, so also from chronic non-steroidal anti-inflammatory drugs like ibuprofen, aspirin, naproxen, all those guys, not Tylenol. Not Tylenol. Tylenol is not an NSAID. Fight me. Tylenol is not an NSAID. So if someone takes NSAIDs for a chronic period, like for a long period of time, like someone with like arthritis or something like that, or someone with like chronic back pain or something like that. So these are typically people who self-medicate. You can end up well, just take my word. You can end up with stomach ulcers. The reason is you knock down the thing that protects the stomach from acid. We'll just say it that way. Okay. Also, alcohol and smoking. Same thing. These irritate the lining of the stomach, and so and the intestine, and they're toxic. So you can end up with an inflammatory response also, and that will end up damaging the the lining, so you end up with an ulcer. So peptic ulcer disease is when there's an actual ulcer. Gastritis is just when there's just inflammation of the gastrointestinal system. So gastritis is a very broad term. Now, where do we typically get peptic ulcer disease? It's almost always in the stomach or small intestine, which they set up here, namely the duodenum. Which remember, it goes duodenum, duodenum, ileum. So it's the first part of the small intestine. Okay. Now, this will obviously happen in older age people because they've had years of H. pylori infection or GERD or whatever. But they'll have a burning pain in their stomach. It'd be a gnawing pain, and it's usually like the upper abdomen. A lot of times this is diagnosed. They know, right? They know that they have an ulcer or something like that. So the symptoms is they could have nausea, vomiting, they could belching, right? They could be like, especially burping up acid or something like that. Or remember, hematemesis. What does that mean? Hematemesis. It means blood in the vomit. Emesis means vomit. So they will be vomiting blood. Hematemesis. And the blood could look like frank blood, or it could look like coffee ground emesis. So that would be partially digested blood. Okay. So it could be both or a mixture. Okay. Um, or could they have melena, or melina, whatever you want to call this. There's several names for it. But remember which one melina is, right? Melena. This is tar, like looks like tar they put on the road. Like it literally looks like tar. It's sticky and it reeks. Not that poop ever smells good, but it absolutely reeks. Very distinct smell, and that's digested blood. Okay. The reason you can end up with melena is instead of vomiting the blood because they're bleeding, from like their stomach, they'll just let it go all the way through to the anus, and so it comes out, as melena. So sometimes this can heal without intervention. It's difficult, but it can happen. Okay, especially in young people. Now they want you to know, which I find interesting, to know the difference between what's called a Mallory-Weiss tear or Borje's syndrome. So a Mallory-Weiss tear, it's a tear between the stomach and the esophagus. Who typically gets this is people that vomit a lot, right? So someone who has an eating disorder like bulimia nervosa or anorexia nervosa, both of those can involve vomiting, by the way. They can get this. So people that vomit a lot, people with cyclic vomiting, people with vomiting from marijuana consumption. Um, there's a lot of there's a lot of reasons you can vomit a lot. Um, Alcoholism, people that vomit with alcoholism. And so what happens is you end up with a tear right here. And so this tear, it's like a incomplete tear. So, this is made up of like three layers. You only tore the first two layers, and this is from belching, right? So when you belch, when you vomit, right? When someone's trying to vomit, it's very violent, right, in the stomach. And it becomes so violent you can tear this area, especially if you do this for a long period of time. And so you can end up tearing, right, on the gastric side of the gastroesophageal junction, which makes it into the distal esophagus. So it may go up, right? So you can end up with this tear down here, and it's an incomplete tear. So how do you think this will present, right? Hematemesis, right? People are going to be vomiting blood. And so if they tell you in the vignette, patient has bulimia and they vomit 10 times a day and blah, 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 now they're vomiting bright blood, right? And they're having lower abdominal pain or upper abdominal pain, you need to be thinking, oh, this is Mallory-Weiss tear, okay? As opposed to, you can end up with something called a Borje's syndrome, right? And so it also occurs from vomiting. So it can be caused by bulimia, anorexia nervosa, alcoholism, blah, 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 blah. But it's a very, very severe form of this because now it's torn through all three layers. Okay, so now you have literally tore longitudinally at that an actual tear in the esophagus. Okay, so as you can admit, it's a complete rupture of the esophagus. So Borje's syndrome is much, much, much worse. And so what happens is Uh, they they will have obviously shock, right? And they could be vomiting blood, right? And so you could also end up with like a subcutaneous emphysema, right? So you could have like or just like you're going to get air leak into the mediastinum, and so which is called a pneumomediastinum, right? Pneumo air into the mediastinum, and so you can see this is a complete rupture of the esophagus. It's very severe when this happens. This is rare, by the way, but it can happen. So they're going to have chest pain and signs of shock. So if you have to differentiate between the two, if they tell you someone's vomiting blood and it sounds like they're dying, right? Borhave syndrome is probably, and they're having extreme pain, Borhave syndrome. As opposed to like Mallory-Weiss syndrome, they're going to be vomiting blood, but it's usually not as bad. Okay. Now, again, I want to point out that the Borhave syndrome, it's a longitudinal tear of the esophagus, right? It tears through the entire wall of the esophagus. So, like longitudinal tear would be like this on me, like that's longitudinally. Okay. Now, again, this is very closely related to alcohol disease, but we should talk about something called esophageal varices. And so, an esophageal varice is so let me say, like okay. Let me start with this. You should know what like hemorrhoids are, right? And that's like engorgement of veins around the rectum. Okay, you probably can imagine what a hemorrhoid is. Well, interestingly, in the same scenario, that can happen in your esophagus. Okay, and so let's talk about why this happens because I don't know why, but this is very, very, very heavily tested, and I don't know why. You do see this. This does actually happen in the real world. But let's talk about something. So when you hear esophageal varices, I want you to think there's something wrong. Or you have portal hypertension. This almost only happens because of portal hypertension. And so remember what I talked about earlier, that all of the blood from your intestines and your stomach and your esophagus, it all goes into the same system, right? All the venous blood through the portal vein. Well, this will eventually empty into the liver. Well, when the liver becomes scarred or irritated, right, but mainly scarred, it slows down, right? So this is like, you can imagine a liver that's nice and soft and healthy, right? Blood can go in and out really easily. But when this becomes scarred and it literally becomes hardened, right? It's actually like hard to the touch, hardened. And it looks like a big old scar, right? And it's all white and crusty and not good looking. That's called cirrhosis of the liver. And the reason we get cirrhosis, one of the main reasons in the United States, is from alcohol disease. Okay? So someone who drinks a lot of alcohol over a long period of time, their liver will quite literally become scarred. It becomes scarred and it becomes hardened, cirrhosis. So that's called cirrhosis. Okay? And so what happens is when you're trying to push blood through a scarred up liver, the blood can't get through there very well. Okay? So you end up with a backflow. So this is like all these lanes of the highway are trying to converge into one point, but the one point is scarred up, right? So it starts backing up. And as it backs up, it manifests its way in several ways. One of the ways this will present is with hemorrhoids. Okay? Fun fact. The other way this can present was something called caput medusa, which is where you'll see veins around the umbilicus. Okay? The most lethal way this will present is with esophageal varices. So in our esophagus, we have a bunch of veins, and these veins will become, since the blood's backing up, engorged. So these veins that are normally nice and teeny tiny become nice and they become thick. And when they become thick, they can become so thick that the walls aren't used to being this swollen up with blood. They can tear. And when they tear, it's called a rupture of an esophageal varice. And they're showing you that here in this picture. You don't need to know what this looks like, but I think it makes sense sometimes for me to show you what this actually looks like. These are esophageal varices. And so, and this is a big one here too, by the way. And so you can imagine these big old veins, like looking in my arm, right? If you have these big veins in your esophagus and you chew a bunch of potato chips or you vomit or something like that, it doesn't take a lot to convince these to pop. And when they pop, the patient's going to start vomiting blood. Lots and lots and lots of blood. So the classical vignette for an esophageal varice is a chronic alcoholic or someone who has hepatitis. Okay, so hepatitis, remember, hepa, liver, titus, inflammation. So hepatitis means inflammation of the liver. It's usually from viruses. And so if someone has like hep B or hep C, hepatitis B or hepatitis C, they can also end up with this because the liver becomes scarred. And so again, the liver becomes scarred. You have a backflow through the portal vein, so portal hypertension is what that's called. And so it starts draining into the tributaries and the hemorrhoids, right, or around the abdomen, or up into the esophagus. What happens is the ones in the esophagus can tear, they can rupture. So you can imagine this big fat vein rupturing. What's going to happen? The patient's going to vomit blood. The stomach lining does not like blood. So as soon as blood touches the stomach, you're going to vomit. And so it's going to vomit, you're going to vomit blood. So I've actually seen these before. Me and Jeff Schwartz actually ran a lady, we called her the Hep C fountain. She was an alcoholic who also had Hep C. And so she was vomiting so much blood, like I don't have the buckets, but on the ambulance you'll see these buckets that we carry that we carry stuff in, and sometimes we'll let patients vomit into them. She had filled up like half of that before we even left the scene. And I was like, oh God, she's gonna die. So we let the family tell the patient goodbye. I was pretty convinced this patient was gonna die. I think she might have died, I don't know. But it was the fastest I've ever drove an ambulance because we had the only way you can fix this is for a surgeon to go in there and clip these and to put like rubber bands on them and to kind of burn them off. So it's a very difficult. It's not difficult, but you have to go to a specialized surgeon to fix this. So all that to be said, what you'll see in a vignette is a patient that has a history of liver disease from alcoholism and or hepatitis, who is now vomiting lots and lots of blood. This is painless, by the way, typically, and it's life-threatening bleeding because you can't stop this, right? You can't apply direct pressure to the esophagus, can't apply a tourniquet, obviously, to someone's neck. So this is very, very deadly when this happens. I think the mortality on this is like 80-90% when these rupture. Yeah, it's not good when this happens. This is the consequences of one of the many consequences of alcoholism. Okay, hemorrhoids, same thing. Now, hemorrhoids can happen from what I just described, portal hypertension, but it more commonly happens from straining from constipation, right? Someone bearing down. As you bear down, you force blood to stay in those vessels, and so they can bulge out. As they bulge out, right, you end up with a hemorrhoid. And so hemorrhoids can be painful if they're below what's called the pectinate line. So external hemorrhoids are very painful typically, but they don't have to be. If they're above this line, this imaginary, like this is the rectum, here's the anus, right? So here's the outside world, right? And so there's this imaginary line to where if you get a hemorrhoid from this line down, so that's like an external hemorrhoid, that would be painful. If you get a hemorrhoid from here out that extends down, that would not be painful. You would not feel that very well. So that's why sometimes when we see external hemorrhoids, they can or cannot be painful. So these can pop as well. They tend to not present with as much life-threatening bleeding, but they certainly can. What you'll get though is bright red blood during defecation. So when they bear down and poop or when they wipe, they'll end up tearing these a little bit, and so they'll get like blood on their toilet paper or something like that. These can also itch. They can also be very painful. They can also be a mass, right? But that's worth knowing that the hemorrhoids do happen. Sometimes these have to be surgically repaired. Like I said, these can be very, very painful or not painful at all, or both, a mixture. I'm actually going to pause the video here and we're going to keep going. This is going to end up being a 3-part video because of how much information it is. So we'll come back in just a bit.